Thank you. Thank you very much. So welcome to the second session today, which is on health services research and basic science for a better understanding of child and adolescent disorders. My name is Niall Boyce. I'm the editor of The Lancet Psychiatry, which is a new general mental health journal. One of our particular interests is in adolescent mental health because it reflects our philosophy, which is to try to fit all of the different exciting and interesting areas of mental health research and treatment together. You will have got a copy of The Lancet Psychiatry on arrival here, and that contains our youth mental health series. And I think that issue has largely the same aims as this session, which is to say that there is cutting-edge research in neuroscience, in genetics. But as we're thinking of that, we also have to think of how we package these advances up into deliverable, acceptable services for young people. So we've got three very, very good speakers, and I'm co-chairing this session with Paolo Sant'Anastasio from the University of Padua, who will speak later. Our first speaker this afternoon is Marieke Zwansweg, who is from the Netherlands Institute for Health Services Research. Marieke is a researcher involved in studies on mental health service need and utilization, with a special interest in child mental health. Her publications include work on help seeking for child and adolescent mental health problems in primary and secondary care, young cancer patients and parents' communication preferences in pediatric oncology, the needs of informal caregivers of people with dementia, mental health interventions in primary care, estimation of the demand for local primary mental health care, and online focus groups. Marieke is currently involved in the development of an integrated registration network for primary health care. Marieke.
Welcome everyone. This afternoon I'll present results of my research on the obstacles on the pathway to care for child and adolescent mental health problems. I'll start with a picture of my daughter. As her parent, I obviously think that she's having a temper tantrum here and she doesn't have a behavioral problem. But as we all know, and as we've seen in the previous presentations, child and adolescent mental health problems are widespread, and they affect children's current and future well-being. The current well-being, they increase the risk of other mental health problems, problems with peer relationships and educational underachievement. In a recent study, we found, for instance, that adolescent school career is negatively influenced by the presence of mental health problems. Adolescents with mental health problems were less likely to complete their secondary education in general, and they were less likely to complete their education at the level at which they entered it, so they were more likely to move down. And more remarkably, their educational career wasn't influenced by the presence of physical health problems, not even by chronic physical health problems such as diabetes or asthma. And child mental health problems increase the risk of adult mental health problems, so they affect children's future well-being as well. So it's important to identify child mental health problems as early as possible and to provide treatment when this is necessary. However, only a minority of children and adolescents with mental health problems end up receiving care. We found that in a sample selected for having mental health problems, only 14% of children and adolescents received care from their general practitioner, specifically for these problems, and only 16% received care from mental health care services. Why are these rates so low? Which obstacles exist on the pathway to care, and how can we overcome these obstacles? In this presentation, I'll present results from various studies to answer these questions. First, a few words about the Dutch youth care system. This system consists of three main parts. First, basic care or universal services, which are aimed at facilitating the normal development of children and preventing small problems from turning into severe ones. Then primary care, which is aimed at detecting problems at an early stage, intervening at an early stage, and referring children with more severe problems to specialized services. And this is also where the Dutch general practitioner is located. He plays an important role in the care for children and adolescents. He's one of the main entry points into the healthcare system, and he functions as a gatekeeper. And finally, secondary care, such as youth mental health care or child protection services. And here we have youth care agencies, which are the formal access points to more specialized services. They assess the needs and situation of families and children with more severe problems and refer children to specialized services. And they're also responsible for the coordination of care. Well, next year, some major changes will take place in this system. All responsibilities will be decentralized from the national and regional government to the local government. This means that municipalities will become responsible for the whole continuum of care for children and adolescents. And this is meant to lead to more integrated care and care which is adapted to the local situation and needs. Well, a useful model to describe the help-seeking process for child mental health problems is this adaptation of the well-known model by Goldberg and Huxley. In this model, help-seeking is perceived to consist of various levels, and to move from one level to the next, so to move to the top of the triangle, individuals have to pass through certain filters, and they are indicated as F1 to F4 here. And some individuals are more likely to pass through these filters than others. So in this way, these filters can be perceived as obstacles for some individuals. And I'll now present results for each of these filters and will describe to what extent they may be regarded as obstacles on the pathway to care. The first filter is problem recognition by parent and or child. Some parents will be perfectly able to manage child mental health problems themselves. Only parents for whom the burden or impact of these problems is severe enough to require outside help will proceed on the pathway to care. So it's not so much the presence of problems per se that leads to service use, but rather the burden associated with these problems. And this distinction between the presence of problems and the burden is also illustrated by our finding that less than half of the parents who indicated deviant CBCL total problem scores also acknowledged that their child had an emotional or behavioral problem when we asked this directly. And moreover, of these children with deviant CBCL scores, 33% were regarded to be in need of services by their parents. So although these children had a considerable number of problems, as indicated by the CBCL, 67% of parents thought that they didn't need any additional care. And results for adolescents were more or less comparable. Of adolescents with deviant CBCL or YSR total problem scores, only 22% were regarded to be in need of services by their parents, and only 30% reported the service need themselves. Well, the next filter is help seeking in general practice. The majority of Dutch children and adolescents, including those with mental health problems, consult their general practitioner at least once a year. The general practitioner is usually the first to be consulted when parents have concerns about their child's health, and therefore the general practitioner may play an important role in the identification and a treatment and referral of child mental health problems. However, we found that when children with mental health problems do consult their general practitioner, they do generally do this in the context of physical problems, instead of directly mentioning their mental health problems. We found that merely 40% of children and adolescents with mental health problems had consulted their GP specifically for these problems in the preceding year. And because Dutch GPs are supposed to function as gatekeepers on the pathway to mental health care, this limited consultation specifically for mental health problems is an obstacle, can be an obstacle on the pathway to care. Well, when children have passed through these first two filters and do consult their general practitioner for mental health problems, the limited problem recognition by general practitioners is another obstacle on the pathway to care. We found that merely 14% of children and 13% of adolescents who were considered to have mental health problems by their parents or teachers were diagnosed with psychological problems by their general practitioner. And more recently, we used a large longitudinal data set of electronic health records of general practitioners, ranging from data for more than 40,000 children in 2004 to more than 70,000 children in 2008. And with these data sets, we could investigate which mental health problems were recorded in general practice, and we could investigate time trends in these diagnoses. And we found that in 2008, 7% of children and adolescents were diagnosed with a mental health problem. And this percentage is much lower than the 14 to 22% of mental health problems in a general child and adolescent population. So this again indicates that there's a number of children with mental health problems who are not identified by their general practitioner. Well, apart from this limited recognition, which mental health problems are recorded in general practice, these figures shows the prevalence of mental health problems in general practice, left for children and right for adolescents. And over the years, this prevalence increased. And as you can see, the green line, overactivity was recorded most frequently over the years, as were anxiety and depression in adolescents. Well, all these results may be regarded as proofs of the limited recognition of mental health problems by general practitioners, but there are a few alternative explanations which I also want to mention. As I already said, when children with mental health problems do consult their general practitioner, they rarely explicitly mention their mental health problems, so this makes it hard for the general practitioner to identify these problems. Secondly, GPs may be reluctant to diagnose children with mental health problems, for instance, because of fear of the stigma associated with the diagnosis or because of limited referral possibilities. And children may function adequately despite the presence of mental health problems. Well, the limited consultation of general practitioners for mental health problems and the limited recognition of mental health problems by general practitioners also limit the possibilities for general practitioners for referring children to additional care. Using the large longitudinal data set of electronic health records I mentioned before, we could investigate referrals by general practitioners for children with mental health problems. And we found that 21% of these children and adolescents were referred to any kind of mental health care in 2008. And a majority, almost 60%, wasn't referred and did not receive any psychotropic medication. And although I do not want to say that all children with mental health problems should be referred, I think these data do indicate that there's a number of children with more severe problems who do not get the care they need. This figure shows the percentage of children and adolescents with mental health problems who were referred to mental health care. And as you can see, they were mostly referred to secondary mental health care and mainly to psychotherapists and psychiatrists. Well, in sum, we found the following obstacles on the pathway to care. The limited problem recognition by parents and or youth themselves, limited consultation of GPs specifically for mental health problems, limited problem recognition by general practitioners, and a limited referral by general practitioners to additional care. For the implications, I think there are two main questions to be answered. How can we prevent children to be in need of additional care? So how can we prevent them from even having to enter the pathway to care? And how can we increase service use for children who do need additional care? I'll now present an example of the first question. So how can we prevent children, how can we prevent mental health problems in children? This is a study which I've been involved in recently. Friends for Life is a school-based prevention program based on cognitive behavior therapy and focused on the prevention of childhood anxiety and depression. It is implemented at elementary schools in Amsterdam since 2007 as indicated prevention program. So for children who show symptoms of anxiety and depression, but who do not meet criteria for a clinical disorder. We investigated its long-term effectiveness under naturalistic conditions, using a sample of 339 children in the intervention group and 157 children in the control group. And these were children with symptoms of anxiety and depression who didn't receive the intervention. We collected self-report data on symptoms of anxiety and depression using the revised Child Anxiety and Depression Scale. And we collected these data pre and post intervention and 6 and 12 months after the intervention. Well, these are the long-term effects on self-reported anxiety. As you can see, children in the intervention group showed significantly fewer symptoms of anxiety than children in the control group, and this effect increased over time from a small to a medium effect size. And more remarkably, the level of self-reported anxiety in the intervention group almost returned to general population level after 1 year. Well, the results for self-reported depression were quite similar. Again, children in the intervention group showed significantly fewer symptoms of depression than children in the control group, and their level of depression almost returned to the general population level after 1 year. And although previous studies have also showed the effectiveness of Friends for Life as indicated prevention program for anxiety, we were the first to also to prove its effectiveness for childhood depression, and we could show long-term effects even when the program was implemented in daily school practice. So this is an example of how we can prevent child mental health problems and can prevent children from having to enter the pathway to care. When we can't prevent mental health problems from developing, the next question is how can we make sure that children who do need additional care will get the care they need? And to accomplish this, we need to address the obstacles on the pathway to care. And these are a few of the ways in which we can increase service use for children with mental health problems. First, mental health literacy programs may increase parents and children's awareness of the presence of mental health problems and their knowledge of where to get the help they need. Because not all children with mental health problems will need additional care. GPs have to be able to distinguish between problems that will go away spontaneously and problems that will persist or even deteriorate without adequate care. So we might increase their awareness of the possible occurrence of mental health problems in high-risk groups, for instance, children who live in stressful circumstances or children who frequently attend in general practice. And we may teach GPs to use psychosocially oriented communication skills, because these skills help parents and children to disclose information about mental health. Efforts to increase the problem recognition by GPs are only useful if there are also adequate treatment options for these children. And I think we need to strengthen primary mental health care, and therefore should develop short-term interventions which can be applied in general practice. More direct contact between GPs and mental health care professionals may facilitate referral and may also be important because of its consultative function. And finally, we need to strengthen the role of schools. Providing prevention programs in schools as Friends for Life gives us the opportunity to reach large numbers of children. And I think school personnel may be important in the identification of child mental health problems and in providing less intensive forms of care. Well, more information about the results I've shown can be found in these publications. Thank you for your attention. Yeah? Are there any questions? Oh, wait, there's a microphone. No. maybe he speaks really loudly.
Thank you. I think the emphasis is more on schools, but no emphasis has been done on families. When the families, I think, are the first to recognize certain mental health illnesses in their own kids.
Mm-hmm. This is what I wanted to stress, that some families will be perfectly able to manage child's mental health problems and won't need additional care. And some, we need to identify the ones who do need additional care. Is that what you mean?
That the family are the first to recognize mental health problem, and it's not the school.
No,
It's always the family.
the school may play a role in...
It may play a role, but the main role is for the family. Don't you agree?
Of course, because they're the ones who will get the help, so they have to acknowledge there's a problem. But I think school personnel may have a role in indicating that there's a problem and indicating where they can get help.
Yes.
Other questions?
Any other questions?